Hi, Shweta. Am I audible and the screen is visible?
Yes,
Reshu ma'am, you're audible and the screen is visible, ma'am.
Thank you.
Yeah. Dr. Serene ma'am, can you please confirm if Puri sir is along with you? You can unmute your mic. Reshu ma'am, we'll wait for Puri sir for another 5 minutes.
Yeah.
Good afternoon, sir. We'll just make you the co-host. Please give us a second. Puri sir, with your kind permission, can I start with the introduction?
Please
Yes.
start.
Thank you, sir. Kiranji, can you start with the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are into the 6th week of the dissemination of the National Operational Guidelines for ART Services 2021. Today's topic is Linkages and Referrals, Care and Support Centers, and IPC. And the speakers are Dr. A.K. Puri and Dr. Reshu Agarwal. Dr. A.K. Puri sir is currently the Deputy Director General at NACO, and Dr. Reshu Agarwal is working as the Public Health Specialist with CDC India. We welcome you both for today's session and requesting Dr. Puri sir to please give the opening remarks.
Thank you, and good afternoon and warm welcome to everybody, all the ART centers and SACs who have joined this online virtual meeting. And this is a very important and interesting topic. In this session, we will be learning about the referral, in referral, out referral, to the inpatient, to this CSC. I mean, to this for the SASAP, you will be sending the patient for COE also, for psychological, psychosocial support also is important. And for that, patients are also being referred. Patients are also being referred to the private sectors also. And they are also needs to be referred to the inpatient care in the hospital itself. So there are several kind of referrals where you have to send the patients. And we have to ensure that those who have been referred out, they should come back to our net also. They should continue their treatment also once they have taken up. Once they have taken the treatment from other department of the hospital, they should come back also. And the session will cover the support centers, and role of the care support center is to follow up of the LFU tracking is a very important thing, and CSC coordination to ensure that the PLHIV is continuing its treatment. And adherence is also important thing. They should continue and they should complete the, they should take all the dosages also. Infection prevention and control is also one of the very important thing. And therefore, in this session, we will also be discussing about the adherence to the hand hygiene. We will use of PPE, safe handling of the sharps and injury management. PP, post-exposure prophylaxis, and biomedical waste management. Besides this, one thing which is very important is that the airborne infections are very important. And the airborne infection control is also, that was discussed earlier also. A part of it will be discussed this time also, how to take care of that. We will be discussing airborne infection control and triage and fast tracking of the patient with the respiratory sign and symptoms. And these are the things which we'll be discussing, and these are very important, and I request all the speakers to be attentive and listen to what Dr. Reshu will be sharing with you. Thank you. Over from my side.
Thank you so much, sir. Thanks for setting up the context and also providing the objectives of this session. And as sir has already alluded that it is a very critical session, and the topic which we are discussing today is very critical. So as sir told, so first of all, we will be discussing more or less about the linkages and referrals which pertain to the ART services. So just to understand that why are we discussing about the need for referral and linkages? What is the need to discuss about this topic? So you would recall from the previous sessions where we discussed about the chances of LFUs at different stages. So there are chances of patients becoming LFU from diagnosis to enrollment, and then from enrollment to ART initiation, and then after ART initiation during the course of the treatment. And we want to minimize this loss at all stages. And that's why these referral linkages are very, very crucial. And from the previous sessions, you would also appreciate that NACO is now moving towards patient-centric services. And you would understand that the needs of the patients, they vary across the care continuum, at whatever stage of treatment the patients are. So from testing, the needs would be different. And once these patients are newly initiated on ART, needs are very different. And then once they are stabilized on ART, the needs are very different. And now the patients are living longer, and they need more chronic care in terms of management of the non-communicable diseases also. So that also warrants needs for linkages and referral with different programs. So we will be discussing all these referral linkages which are required with respect to the ART services in more details. So first of all, we will discuss in referrals. In referrals means how the patients would come to ART center and what are the SOPs for these in referrals. So you would appreciate that in terms of in referrals, you basically get all the patients from ICTCs. That is the main point of entry. But some of the patients you come to know that they at times they directly walk in from the private sector, or at times you get some referrals from the inpatient facilities also, that the patient is HIV positive, known or not known at times, and then you get a referral at the ART centers directly. So but then for all the referrals, I think the entry point would be ICTC, like from wherever the referral is coming from. But all these different dimensions or different aspects from where the referrals are coming in, they require a different set of SOPs, so that we are able to minimize any loss or gap in terms of initiating these patients on ART or maintaining these patients on ART. So first of all, we will discuss about the ICTCs. And about ICTCs, we already discussed about the referral from the ICTCs in our first session when we talked about the ART initiation piece. So just to quickly revise what we really understood about the ICTC referral. So basically ICTC, as I said, is the first point of interface which gives entry point to all patients to come into care and treatment services. And the responsibility of ICTCs with referral are very, very critical, very crucial. And the ART center, the ICTCs should ensure that the referral should happen to the nearest ART center or link ART center, which is convenient for the patient, and the information should be updated in IMS. And then post-test counseling, when the patient has been detected positive and the ICTC counselors are doing post-test counseling, at that time, talking about the benefits of ART, the importance of adherence, living with positive living, with HIV, and also the involvement of the caregiver. These pieces are very critical, and ICTC counselors should take a note of all these points during their post-test counseling. And then in terms of because we are talking about minimizing the gap or minimizing the loss between ICTC and ART, and you would appreciate from your ART centers, at times, even when you have an ICTC which is next door or next building, still there are losses which are happening. So it is very important for the ICTC counselors to explain the process of registration to all the patients, so that they are not really lost when they reach the ART center, and they are not confused about what is happening with them. Particularly for the co-located ICTCs, it must be tried that accompanied referral, if possible, that should be tried, so that the linkage loss can be minimized between ICTC and ART. Also for non-collocated ICTCs, wherever possible, peer navigation, especially like for KPO populations and also for pregnant women, accompanied referrals should be done. At least for these group, it is must. And for others also, if possible, accompanied referral or peer navigation can be tried. But key populations and pregnant women is a must, and there is a provision in the program for peer navigation under TI scheme. Then once like patient is registered at the ART center, it is the responsibility of the ART counselor to provide the feedback in IMS. So the data should be entered. Yes, this patient has reached and this is the ART number. So all that information has to be entered in the IMS, and this information would flow back to the ICTC so that they know that this patient has reached. And the patients who would not reach the ART centers, for them, the ICTC counselors are required to prepare a line list and then do a follow-up either by phone or home visits. This piece is very important from in terms of bridging the gap between ICTC and ART centers. Next, we will discuss about the patients who are either detected, who come to the indoor facilities and they are detected as HIV positive, and these are really sick patients. Especially this problem is quite common in the tertiary level hospitals or tertiary institutions. So for this kind of referral from inpatient facilities, it is very important, and especially for tertiary level hospitals where you get a lot of patients who are coming from even far-flung areas and getting admitted because of some OIs or some serious condition or complication, and then a referral coming to the ART center. So for the inpatient in referral, it is good to identify a focal point at the ART center, and this focal point for all the in referrals could be preferably the staff nurse or the medical officer. And then all the indoor departments from where the ART center gets the patients, they should also be notified or informed about this contact person, so that whenever there is a person who is HIV positive and is in the inpatient ward, then this information should be flowing to the ART center. All the new diagnosed patients from wards or inpatient services should be routed through ICTC. So in case that ICTC detection is not, HIV detection is not done at the ICTCs, at times you will have patients who have been like diagnosed for HIV in private sector, and then they come to the hospital. So if they don't have a positive ICTC report, then their detection has to be done at ICTC first, and then they should be registered in ART care. Counselors should conduct ART preparedness counseling for all the newly diagnosed patients, and at times, like when these patients are not able to visit the ART centers and only their files are sent to the ART centers for enrollment, in such cases a bedside counseling should be done for all the patients. Then, of course, now with treat-all, ART initiation is very critical, and it should be encouraged as part of the hospital admission. So till the time the patient is in the hospital, effort should be made to start the ART as well. And to this respect, ART nurse should carefully follow up all the patients admitted in the hospital and ensure that they are initiated on ART before the discharge. Some patients might require some specific services with respect to advanced disease management or maybe management of TB. So those specific services should be provided, which are like under the purview of ART centers. As a good practice, it is recommended that a logbook should be maintained about the visits done to the inpatient wards by the staff nurse, and these visits should be done mainly in afternoon when the load at the ART center, the outdoor patient load at the ART center is comparatively less. And this exercise of in referral has to be monitored by SMO or MO, whoever is in charge at the ART center. Then it should be tried that the patient must visit the ART center before discharge, and he is counseled appropriately, because patient should know that how where is he getting the ART from, and like once he goes back, then his ART has to be continued. So it should be tried that the patient visits the ART center before he's discharged and going back home. Information about the availability of the nearby center to the patient's residence, and especially again, this is very common problem in the tertiary level hospitals where you have patients coming from far-flung areas, from neighboring districts. And then like once they are treated or managed, and then they are referred back to their own districts. So for these kind of patients, it is advisable that these patients are provided information about the availability of the ART center to their near to their residence, and if required, a transferred out provision should be also be made. Now coming to the in referral from private sector. So this is and we from the field we really find a lot of queries coming about the in referral from private sector. So again, as I said earlier, that for any registration in ART center, positive ICTC report is important. So all patients who are coming from private sector, if they don't have a ICTC report, then they should be first asked to get a HIV test done at the ICTC and then get registered. Then during the preparatory phase, patient should be advised to continue on same ART, whatever the patient was taking in the private sector. And we should try to minimize this preparatory phase. And as we discussed in our previous sessions also, that program is now moving towards rapid ART initiation or same day initiation. So those points should be like considered here also. Baseline clinical evaluation and investigations of these patients who are coming from private sector, whatever is necessary should be done. Then they are required to sign the consent form, which is done for all the patients. And PLHIV should be offered appropriate regimen which is available under the national program. So at times what happens, patient is taking some ART outside the program, and that those drugs are not available within the program. So whatever best possible option we have within the program, or whatever appropriate regimen is available, that should be provided. If the patient is taking ART in the private sector for more than 6 months, it is a good practice to do a viral load testing before initiating ART from the ART centers. And if the patient is virally unsuppressed, then a routine procedure for referral to SASF should be followed, and then the recommendation on the next ART or for a switch should be taken. Coming to the out referrals now. So as Puri sir was also speaking, for out referrals, patients do need but during different points of time, they do need services from other departments within the hospital or maybe outside the hospitals. So as you can see in this, on this slide, what you see is first you have these outpatient department where the patient might be needing some specialty consultation, say they are having non-communicable disease, diabetes, hypertension, or hepatitis. So for any such condition, they might need a consultation from a specialty department. So they need to be referred there. Then some of the patients would come to the ART centers and they would need some inpatient care or would need hospitalization. They might be very sick. They might come with advanced HIV disease and they need to be referred for inpatient services. Third, we need to refer the patients for investigations. So all patients, whenever they are registered, they should undergo baseline investigations, and then even as a follow-up, whatever recommended regimen, recommended lab test starts to be done, those needs to be done. So the investigation piece is very important. So all these three out referrals which I spoke are within the institution, but they are beyond the ART center. So they may be some outpatient department, some inpatient department, or for the investigations. Then outside the facility in which the ART center is located, you might require to refer a patient for SASF consultation. And for SASF consultation, as we know, a e-referral needs to be done. Then patient, if especially this is true for some of the hospitals which are at sub-district hospital or even at the district level hospital, but do not have infrastructure to manage some of the complex cases. So some of the patients from these ART centers might require a referral to a higher center for management of the complications, or maybe for management of the OIs or advanced HIV disease. Then the other thing patients need is basically the referral for psychosocial support, and for this we usually refer our patients to the CSCs. And now program is also coming out with the linkages with the mental health, national mental health program, about which we discussed in the last session also. So that piece would also be important. And lastly, some patients might require a transfer out to another center. So we will discuss all these out referrals also in more detail. So referrals within the facility. So within the facility, as we said, like no, these referrals would be for the outpatient consultation, maybe for indoor admission, or maybe for some of the investigations. So it is very important for the ART centers to establish referral and linkage mechanism with all the relevant departments where you would be referring your patient. And to optimize or to have effective mechanism for linkage, ART team should meet at least once in a quarter to review the ART services and also the interdepartmental linkages. And if there are any issues, any problems, then those issues should be identified and resolved in these meetings. If these quarterly review meetings separate or a dedicated ART team meeting is not possible, then whatever institutional meetings are happening, the agenda on the interdepartmental linkages should be part of those larger meetings which are happening in the institution. And these meetings should be ideally minuted, and efforts should be made that the patients or the PLHIV are not discriminated against for any reasons. So for referral, so whenever the referral is happening within the institution, ART nurse would be the responsible person for tracking the referrals, and the referral should be either done using the hospital referral form, or the green book of the patient, or the common referral form which is given as an annexure in these guidelines. So coming to the, we already discussed about this, like whatever are the needs for outpatient consultation. So mostly patients would require like ANC care, or to be referred to the gynecology department, pediatric department, skin and VD, then chest or tuberculosis department, medicine, surgery, non-communicable disease. So whatever departments your patients are being referred, it is good to have linkages with those departments. Then for inpatient, as we discussed about the patients who are identified as HIV in the indoors, so the same mechanism would be applicable for the patients who need hospitalization, who are first registered at ART center and then they need hospitalization. So again, the staff nurse would be the focal point, and whatever needs of these patients may be, like if they need some advanced disease package or diagnosis of some particular OI or TB, so accordingly the staff nurse should coordinate with the respective departments. ART nurse should also carefully follow up the admitted cases, and at times what happens, like these patients are admitted for the initial OI management and stabilization of the patient, and the ART is not initiated. So if ART has not been initiated, such cases it should be ensured that ART is initiated before the patient is discharged, and the preparedness counseling should be provided by the counselors. Now, the investigation piece, I think we already discussed about the baseline investigations and the follow-up investigations which are required for the patients. And again, it is very important that PLHIV should be prioritized or given preference for the investigations in the hospitals. And obviously, these investigations which are laid out in the guidelines should be provided to all patients free of cost. CESEP referral. So as we were discussing, that the patients either if they are failing on their current ART, or if they have severe side effects which cannot be managed at ART center level, or if they have complications, or they have some serious OI, sorry for this spell mistake, if they have a serious OI, then these patients need to be referred to the CESEP, and e-referral is preferred for referral to the CESEP. So we already discussed about the protocols for referral to CESEP in the session on the provision for second line and third line chapter. So you can refer to those slides for detailed discussion. Referral to other hospitals. So if especially like the ART centers which are located in sub-district hospitals or area hospitals where the facilities for management of OIs or comorbidities or advanced disease are not there, linkages with higher hospitals should be established, and SACs and wherever DAPCUs are present, they should support this mapping of the facilities where the patient can be linked. Then referral for the psychosocial support. Again, this is very important. And in the program, basically what we are suggesting is you refer the patient to care and support centers. If the patients, they belong to KP groups, then they can be referred to a TI NGO or a CBO, so that they are provided other services also there. And some patients might also need rehabilitation services, like patients who are injecting drug users, or those who are alcoholics. So those patients can be sent to the rehabilitation centers also. Now the other thing is the transfer out patient, and in the previous sessions I think we had a lot of discussion about the transfer out. So this slide gives you the SOPs about the transfer out. So when do you do a transfer out? One, you do a transfer out when the patient requests for it. So like if the patient is shifting to a new location and he wants to get ART from somewhere nearby to the new location, that would be the one scenario where transfer out is done. The other transfer out is done for the programmatic reasons, like when you have new ART center coming up in the vicinity or near the patient's residence. So because the program is scaling up ART centers, and gradually all districts are getting ART centers, and even in high burden districts new centers are coming up. So at times when a new center comes, then the ART center has to explore the possibility of transferring out the patient to the nearby ART center. So whenever such a request comes, or whenever a new center is established, the counselor should identify the ART center which is convenient to the patient, and discuss with the patient that he can get a transfer to this new ART center. And then once that patient is okay with taking a transfer out to the new center, SMO or MO should ascertain that the patient does not have any condition that cannot be managed at the recipient ART center or the new ART center where the patient is being referred. Because at times, and this is very true, when the patient is having advanced HIV disease or undergoing some treatment for OIs, and the ART center in which he is currently is in a tertiary level hospital. So but you are planning to refer this patient to a sub-district level hospital. So in those cases, it has to be ascertained that whatever condition the patient is having would be managed at the new or the recipient ART center or not. And then when the patient is being transferred out, he should be given 1 month drug or multi-month drug based on the stability criteria. So if the patient is stable, he can even be given multi-month drug while doing a transfer out. And then he should be provided appropriate information and the contact details of the recipient ART center. And this piece is very important, that whenever you are sending the patient to a new center, you have to do it after giving appropriate information to the patient and providing proper contact details of the patient. So patient should not, it should not happen that the patient goes to the new ART center, which is in a big medical college, and he's lost there. Then in terms of the data management, so the data manager of the parent ART center would indicate the transfer out in the IMS and then generate a transfer out form. And the original white card should be retained at the ART center, scanned copy along with the transfer out form and the contact details of the new ART center or the recipient ART center is given to the patient. And when the patient reaches the recipient ART center, then the recipient ART center would confirm in the IMS that the patient has reached. The recipient ART center will also download the necessary details of the patient from IMS and create a new white card for this patient and assign a ART enrollment number as per guidelines. So transfer out will only be confirmed after the recipient center has confirmed that the patient has reached the recipient center, and then only the transfer out would be taken as a complete thing, and it would be accepted in the IMS. Otherwise, if the patient does not reach the new ART center or the recipient ART center and his pills have exhausted, then these patients would be considered LFU. So there are different scenarios also. At times what happens, because what I was talking was that the patient was at the parent ART center and then the parent ART center initiated the transfer out. But at times what happens that the patient has gone out and then he goes to the ART center to the in the new geography and asks like, no, I want my ART from here because I have shifted. So in such cases, the recipient ART center should send a request via mail or phone to the parent ART center so that the parent ART center can officially transfer out that patient in IMS. And then once that transfer out has been officially done, then the recipient ART center can accept that patient as a transferred in patient. So this at times like this situation arises like especially for the migrants, because they migrate to the new district and then they go to the new district and ask the ART center to give them drugs. So at times like ART centers are not sure like what to do in such cases, but during such cases you have to ask the parent center to do an official transfer out. Also, as we discussed in the earlier session, especially in the COVID scenarios, a special permission was given that if the patient is registered in one center and if he or she reaches some other ART center for ART refill while traveling or during some restrictive situation, in such situation, as a stopgap arrangement or a temporary arrangement so that his ART is not interrupted, this patient should be provided ART. And these patients are under IMS, these patients are referred as in transit patients. So this is just a stopgap arrangement or a temporary arrangement. And if the patient plans to stay longer in the new geography, in those cases, an official transfer out from the parent ART center should be asked for. So I think, okay, let me complete the care and support centers also. So moving to the care and support centers, so as we were talking about the psychosocial support, I think that is a very critical piece of the care and support centers. And the the care and support centers are basically, they have four main objectives. One is to improve the treatment adherence and education of the PLHIV. Second, to leverage on the schemes which are available for the patients, and then to convince them or to motivate them for positive living. And then fourthly, they should be linked. One of the objective is the early linkage to care, support, and treatment. So whenever a new patient is diagnosed, he or she should be linked to treatment. So the major activities which are undertaken by the CSCs is basically the intensified peer support services for prevention of LFU. And we already dealt about the prevention of LFU in the previous sessions, that the patient should not become MIS or LFU. We have to cater to the needs of the patient so that he is continuously taking, he or she is continuously taking ART. So intensified peer services for prevention of LFUs by reaching out the PLHIV who are newly initiated on ART, or the patients who are non-adherent or who are virally not suppressed are undergoing the step-up counseling. So for these patients, CSCs provide intensified peer support services. Then tracking of the LFU and MIS cases. So if the patients do not come back, then the CSCs, they do support in tracking of these patients. Follow-up of the family members for PLHIV, for HIV testing, and then early linkage of any positive family member with the ART services. Counseling and support group meetings, intensified case finding among PLHIV for TB, and then also doing some sort of advocacy or sensitization of the local stakeholders to enhance the linkages of the patients to the social welfare scheme, and also to reduce the stigma and discrimination which is faced by PLHIV. So for the coordination between ART centers and CSCs, it is very important that the ART centers should display about the location and address of the CSCs, the services which are provided at CSC, and the contact details of the CSC in the display board of the ART center. So these information should be available to all the patients. Then the patients who are registered in care and under active HIV care should be referred for registration in the CSCs, because CSCs provide a wide range of services which are outside the medical services. So it is encouraged that the patients who are registered at the ART center should also be registered at the CSCs. And other than doing the providing peer support to peer HIV and then doing LFU tracking, now a new concept for CSC has been introduced, which is like case management approach. So especially for the patients who have advanced HIV disease, comorbidities, or children and adolescents who are on ART or who have not been initiated on ART, for them, the CSCs would provide more of a peer support or a case management support, because what we see, like, in these patients who are with advanced HIV disease or comorbidities, the mortality rates are really high, and these patients need a wide range of services. So CSCs could support PLHIV in availing those services which are required. Secondly, among children and adolescents, it has been found that the adherence rates are comparatively low when you compare with the adults, and even the viral load suppression rates are very low. So specifically for children and adolescents, CSC are now asked to do a case management approach. In terms of the follow-up, so CSCs are required to follow up the patients who are newly enrolled in HIV care, but they are not initiated on ART. Then tracking of the missed and LFU cases. Then the patients who are initiated on ART for the first 3 months to provide them peer support. Then the patients who are virally unsuppressed or undergoing step-up counseling, or the patients who are not adherent to ART. So those patients should be followed up by CSCs. Then the last, PLHIV with the advanced disease, or the children or the adolescent for case management. So these are the groups which needs to be followed by CSC, and ART centers are encouraged to follow, share the list of these 5 categories of patients with the CSCs. Especially for the first 2 categories, when we talk about the patients who are not initiated on ART or the patients who have become MIS or LFU, the follow-up needs to be done on a weekly basis, and we discussed about the modalities of follow-up when we were discussing about chapter 3 of these guidelines. So you can again go back and see, like, how the overall LFU tracking algorithm needs to be followed. But here I just want to reiterate that a weekly exchange of lists should be done. So on a weekly basis, ART center should be providing the list of fresh LFU or missed cases or the patients who are not initiated on ART, and by next week, CSC should be providing the feedback. Then to strengthen the coordination between the ART and the CSCs, ART CSC coordination meetings need to be done, and these meetings need to be led by the nodal officer or the SMO in MO in charge at the ART center. And then at the state level, state oversight committee meeting is done. So this is all about the referral linkages and the CSC piece, and I think I can pause here briefly, and if there are any questions, we could take them for a while. Shweta, are there any questions in the chat box?
Yes, ma'am, we have questions in the chat box.
Or if the participants want to unmute, I think we can just do it.
I'll do that also. Participants can now unmute their mics if they have any questions. I'll just read the questions from the chat.
Sure.
In case HRG or IDU diagnosed at some other ART district reaches at other ART center for initiation, He is brought in by the TI NGO, and the patient doesn't have any valid ID proof. What should be a referral or initiation guidance in such cases?
Yeah, so for such cases, especially this happens like with the IDUs, or at times people who have migrated from other districts and they don't have a valid ID. So if these patients are being accompanied by a TI NGO or a CBO, then these TI NGOs or CBOs can be asked to take responsibilities of these patients in terms of follow-up. Because why we are taking the IDs of these patients is just to ensure that we will be able to follow up these patients in future. So these patients should be linked to the TI NGO or CBO, and if they don't belong to a KP group, then these patients can be linked to the CSC, and that's how their treatment can be initiated, and CSCs can, or the NGO or the CBO can do a regular follow-up with these patients.
Okay, ma'am. Next question is, if a patient is transferred out and doesn't reach the ART center, comes back to the parent ART center after 2 months and ask for transfer out to some other ART center, what should be done?
So in such cases, because you had already made the transfer out, but the patient did not reach the recipient ART centers, obviously this patient would reflect as LFU in your ART center, and you can always initiate a new transfer out for this patient.
There's another question which is related to how to generate a transfer out form in SOCH that has been answered by Sudhir sir in the chat box.
Okay. Right. Dr. Sudhir, you want to comment on that?
I'll just give you my access. Sudhir sir, you can unmute.
Yeah, so I just replied in the chat box only. So, that is under process. We are working on that. The transfer out form, auto generation of transfer out form will be, that facility will be available under the source in the next period. So till then, if that facility is not available, nothing is like holding you for transferring out people with the traditional way of transferring, like hard copy form to be filled at your level and provided to the patient. If patient has reached directly at some place without the transfer out form, as Dr. Reshu was mentioning during the session, like that recipient center will inform to the center, the original center, like from where the patient is actually enrolled. So that center will electronically share the soft copy of the transfer out form, and then the other things can be taken care at the recipient center. So those things can be taken care, like this facility will be there in source very soon. But till then, we can continue with the current system of whatever is like available.
Thanks so much, Dr. Sudhir.
I think we can move on to the next.
Madam, good afternoon.
Yes.
Good afternoon.
Good afternoon, yes.
And previously we were giving transfer out cases, the original white card. And now in this guidelines, it is mentioned that we have to scan the white cards and keep the white card with us only.
Yes.
This is a change, right?
Right. So basically, this guidance has changed from the previous guidance, and now, as Dr. Sudhir was mentioning, we are moving to the electronic transfer out. So very soon this provision, because when we are discussing these guidelines and the SOCH things are being done, so very soon there would be provision in the SOCH to do the transfer out electronically, and we don't want, like, in case if the patient does not
carry the
yeah. So because your patient card is retained at the ART center, and at times what is happening nowadays, the problem is when you give the white card to the patient and patient does not reach the new ART center also, right? So the record is neither available with your center nor with the new center. And in case if the patient comes back, or if there is any query or any like a medical legal issue around this, then you will not have any information. So that's why we are advising that the original white card would be retained with the ART center parent ART center, and a
Recipient
scanned
ART
copy would
should
be given.
take a new white card.
Yes.
And another thing you mentioned, madam, if a PLHIV is on ART from a private sector for more than 6 months, we have to refer to SASAP.
No, we ideally, if possible, we should do a viral load test.
Yes.
If patient is suppressed, then you can provide whatever appropriate regimen is available in the national program.
First line, whatever is
yes.
recommended by NACO, we have to start with the same, irrespective of the regimen taken by the PLHIV at private sector.
Right. But in case if the patient is unsuppressed, then it is good to take a SASAP opinion on the second line regimen.
Okay.
As we do for our own patients.
Only unsuppressed patients we have to refer.
Yes, only the unsuppressed ones.
Okay, thank you, madam. Thank you.
Right.
Can I comment for a minute?
Yes, please.
Okay. My issue is most of the times when we refer the patients and try to track them through CSCs, the reply usually comes as the address is not traceable or address is not available. Even the contact number which is given by the PLHIVs is wrong. And if somehow people reach to the houses, PLHIV feel bad about it. Why did you come to our houses? So both ways, it's a catch-22 situation. If you reach, they feel bad, or otherwise most of the times reply from the CSCs are after 1 week, the address is not traceable. So this time, what is happening is our list is getting long and long. What shall we do? Shall we, after a week, LFU should be dropped off and new list should be made? What should be the plan in these cases?
So I think we discussed this piece in when we were discussing about the monitoring of PLHIV in great detail. So if you can just go back to that chapter and see like how it is to be done, that would be really helpful. So if a patient is not traceable for 6 months and adequate effort to track back the patient has been made, so obviously you are not supposed to share that list with the CSC anymore, but then the patient would still be LFU. But in terms of your tracking efforts, you should not invest too much of effort on that piece. So but having said that, I think the issues which you raised first was wrong address and patients not accepting the home visits. So I think for the wrong addresses, again, as we discussed in previous sessions, preparedness counseling and the rapport building with the patient is very, very critical. So it is very important that you tell the patient why you want the address. And he should be assured that if he's coming regularly, we don't need his address. We don't want to visit him. But only in case if he does not come back, and then we would want to know his whereabouts. What is he doing? And we are really worried about him. And that's why we want the address. That's how the patient, it does not happen in one session, but it takes time. So every time when you start a new patient, this rapport building, and every time asking please give us your exact address, that needs to be done. Even for the existing or the older patients, address has to be reconfirmed during every visit. That is the guideline, because we should realize that if we are giving wrong address to the CSC. Hello, am I audible?
Yeah. Yes, you are audible, madam.
Okay. So if the address which is being given by the ART center to a CSC which is wrong, then the entire effort actually fails, and that's how we get it. And believe me, there are some centers where the LFU rates are very low, and if you see their tracker list, you will not even have a single patient saying the outcome wouldn't be saying that a wrong address. So the onus lies with the ART center doing a very good rapport building, and also confirming and reconfirming the address and updating it at a regular interval.
Sure. Thank you, madam. Thanks for the reply. Thank you.
I can, Dr. Reshu, if I can add to
please,
what you were saying, sir. So, Jayapalji, the question is actually the entire the Gita of care and support center. If person is saying is not available at the given address, the address shared was wrong, the phone number was wrong, or person is denying for the home visit, we need to understand the reasons behind these things. If a person reached at ART center, before that person might have tested at ICTC, have been registered at care and support center. There is a guideline for care and support center for the initial visit. Like once the person is registered with the ART center, that initial 6-month regular monthly visit has to be done by the care and support center for the address verification. So many people must have like contacted this person in the initial period of 6 to more than 6-month period. So if still the address is wrong, the number is wrong, person denied for the home visit, we need to understand reasons behind that. Something known as the potential loss to follow-up. At the time of registration, we can identify such type of people, like those who are having potential to loss to follow-up. Maybe they are migrant, they are from the key population group, they are young and adolescent, they are not having their job, they are not having their like homes, or they are regularly shifting their homes. So those factors we need to understand. Or sometimes like a particular NGO or particular geography people, particular industry people are like prone to migration or prone to like loss to follow. So if we understand those factors and take some step proactively, we will be like able to reduce such type of loss to follow. Secondly, at the time when you get this feedback, it will be good, like this will help you in preventing future loss to follow. But when you get this feedback from the care and support center, just try to look into the available records of IPTC and care and support center, if the address given by the person is the same at all the places or not. I have seen from my experience, I can tell you the address written at the top of the white card and the address on the address proof which is there in the white card is different. And sometimes address at ICTC and care and support center is entirely different. So there are 3-4 addresses or 3-4 contact numbers which may be available within our system. If we can triangulate this information, we will be able to reach out to the people. So that is the things which you can do for like closing your loss to follow-up gap, and secondly to prevent further loss to follow-up. Thank you.
Sure. Thank you very much. Thank you very much for this explanation. I appreciate it, sir. Thank you.
Thanks so much, Dr. Sudhir. So I think we can take rest of the questions at the last now. I just thought like now we should break the monotony so that it doesn't become very like disinteresting. So moving to the next topic now on the infection prevention and control. So infection prevention control is a scientific approach that deals with the practical solution designed to prevent harm caused by infections to the patients as well as healthcare workers. So I think it is very important for the staff to realize that we want to prevent our patients as well as our healthcare workers. Like, no, I mean, they have to prevent or they have to maintain their own health also. So it is very important to follow all the infection prevention control practices at ART center. And especially when it comes to ART centers, because we are dealing with patients who are immunocompromised and they really have a very high chance of acquiring infections from the hospitals or the community settings, the infection control practices become very much important when it comes to patients. Then one example, and especially like we usually talk about infection control practices with respect to tuberculosis. So it is a preventable disease, and if you if the ART centers or in the healthcare settings we are like following airborne infection control practices, obviously we would curtail the transmission, which can be which can happen to the patients who are not infected, and they can like acquire this infection in the hospital setting. So this can be definitely prevented. And now, like, I think everyone is like sort of, I'll say, pandit in the infection prevention control practices now with COVID-19 pandemic things. And we all know, like, what are the main IPC practices which needs to be followed at all healthcare facilities. So in terms of types of recommendations, so basically these recommendations for airborne infection, for infection prevention control can be divided into two types. One is the standard precaution and the other is the transmission based precautions. So standard precautions means that these are the precautions which needs to be followed for all patients at all times and for all activities. So whatever procedures, activities are being done, even if it is just outdoor consultation, even then these standard precautions needs to be followed. And when we are talking about the ART centers or link ART centers, obviously, like, we have reasons to ensure that these standard precautions are followed. And in terms of, like, detailing these standard precautions, so for the most important is the hand hygiene, then we have respiratory hygiene or the cough etiquettes. And you all would remember that at the ART center we encourage all the patients, even before the COVID, we used to encourage all our patients to either wear mask or use kerchiefs to cover their mouths, especially while coughing or sneezing. Then personal protective gears, injection safety, safe handling and cleaning of the disinfection and disinfection of the equipments, environmental cleaning, safe handling and cleaning of the soil linen, and last but not the least is the biomedical waste management. So hand wash, I think it is now with the COVID, again, we all know that running hand water facility should be there in all our ART centers. And then if possible, we should have alcohol based hand rub also to be used as a sanitizer. The information about hand hygiene should be displayed at the ART centers. And for the healthcare providers at the ART center, or for the staff at the ART center, it is very important that hand hygiene is followed before touching a patient, before doing any clean or even aseptic procedure. Then if you are, like, in touch or in contact with the body fluid, then obviously, and after touching a patient or touching a patient surrounding. The next is the cough hygiene, and I think I will not go in too much of detail, but yes, at all times when the patients are there, and I think this does not need any introduction now with COVID, but again, just to reiterate that face mask or tissues or cloth mask, cloth covers should be used. Personal protective equipment, so like in whatever kind of work a person is involved in, like somebody who is like drawing blood should always have like gloves. Somebody who is like in direct consultation of the patient should have surgical mask. And if you like in your settings, if you get a lot of TB patients, or it is like when you have the surge of COVID pandemic, obviously the healthcare providers should prefer to wear N95 masks. So based on the situation and also based on the kind of activity which the staff is conducting, appropriate PPE should be used. Injection safety is also one of the parts of the standard precautions, but at the ART centers, I think it is very, very minimal. So, but again, if there are like any needles or injections which are being used, they should be disposed properly, and they should be like destroyed before disposing them. Recapping of the needles should not be done at all, and multi-dose vials should not be used. Then it is very important for the ART center staff to ensure that all the equipments which are used at the ART centers are appropriately cleaned and disinfected. Environmental cleaning is again a very important part, and for ART centers, even from very beginning, we used to recommend that wet mopping should ideally be done instead of doing a dry brooming. So that piece is very important. And whenever, if possible, I should say that sodium hypochlorite solutions should be used to clean the dirt which is available, which is there at the ART centers. Then cleaning of soil linen is not important for ART centers. Then the biomedical waste, and especially at the ART centers, a lot of waste, and even where you do the CD4 lab, sample collection, a lot of waste is generated, and you need like sort of SOPs for at every step, like when generation, or how to segregate the waste, how to collect it, transport it. And as per the guidelines of Government of India, it is very important to use the color coded bins. So these are usually like available in your hospitals, and there are specific recommendations from your hospital. So those recommendations need to be followed. All infectious or toxic material which is being generated at ART center should be disposed on a daily basis using the bio waste medical management mechanism of the hospital itself. So this is just to remind everyone that the ART centers are very much part of the hospital. So whatever management biomedical waste management mechanisms are available at the ART centers. Those should be utilized for the ART waste also. These are the color-coded bins and how to segregate the bags. And of course, there might be some deviations in your states or in your hospitals. So based on whatever is the recommendation from your hospital, these color-coded segregation of the waste should be done. Coming to the transmission-based precautions. So transmission-based precautions are the precautions which are used in addition to the standard safety precaution, and they are aimed particularly to avert or minimize the chances of some particular infection. So we know, like I think from COVID, we know now that what specific precautions are to be taken. Then tuberculosis. So I mean, for transmission based, you normally follow all the standard precaution, but then you add the particular precautions which are needed for a particular infection. And mostly the transmission-based precautions are divided into two parts. One is the contact precaution and then the airborne precautions. So for contact precautions, you use the contact precautions for patients with known or suspected infections that represent an increased risk by contact transmission. And then for the airborne precautions, use of airborne or the droplet precautions for the patients who are or suspected to be infected with pathogens transmitted by the airborne route or by the respiratory droplet. So you follow the airborne precautions. Coming to the airborne infection control practices, I think everyone knows about this hierarchy of the measures which needs to be taken. So at the top, we have managerial practices, then administrative practices, then environmental, and then PPE. So managerial means that this is more in terms of the policy, having infection control committee constituted at the at your hospital that is meeting regularly. ART center is should be very much part of these hospital infection control committees, and a risk assessment should be done at the ART center in terms of the infection control practices which are being followed. Also, as per the guidelines for airborne infection control, the TB risk should be, and even for the staff, should be like conducted annually or periodically. And then the ART nodal officers at the ART center should ensure that all the guidelines prescribed by ministry or national TB program, or like with respect to COVID, like whatever new guidelines come up, they should be like followed and adhered at all the ART centers. So this is more in terms of like managerial or the policy things. Then you have administrative or environmental controls, which are more in terms of like, I mean, what we used to do in or what we are doing in COVID is basically like maintaining physical distance, covering or using a face mask. So those are like basically the administrative measures. So especially like, and for ART centers, the recommendation is that the ART center should not be located closely to the chest clinics or the designated microscopy centers or the DOT center where a lot of TB patients visit, because there is a risk of cross infection of PLHIV if they are sitting or like waiting in an area which is very near to the TB department. Then at least 6 feet of distance should be maintained at all times at the ART centers when the patients are getting registered or when they are like sitting and waiting for their consultation turn. So 6 feet distance should be done. And in this pic, you see like this is from one of the ART centers only, that it is possible now with COVID. We all have learned this, and this does not only prevent you from COVID, but also from other airborne infection control. So it is very important. And now, I mean, I think we really had a practical that it is feasible and it can be done. It can be adopted at ART center. So it is very much recommended. And please, I mean, whether COVID or no COVID, standard practices should be, in terms of the airborne infection control, should be practiced at all ART centers at all times. Then as far as possible, keep the your cabins, your rooms open and ventilated. And in many of the ART centers, what we see is like, there are windows, but then they are like blocked by some almirah or some other chairs, tables, etc., and they are not opened. So it is, please, like, just go back to your ART center and see if there are any closed windows which can be opened. Please open those windows. And then the unidirectional sitting arrangement should be there. And in this picture, you can see, like, how the sitting arrangement should be there. So when you see in the first picture, where you see that the healthcare provider is sitting here and the patient is sitting here, and if this patient coughs or sneezes, that would, and you have the window at the back. So when this patient coughs or sneezes here, this would directly go this side, and this increases the likeliness for the healthcare provider to get infected. So this kind of seating arrangement is not recommended. What is recommended is basically when you have a window here, the sitting arrangement should be crossed, so that if the patient is coughing, the droplets would go towards the window, towards the ventilated area, and the healthcare provider sitting here is prevented. Then just to continue the administrative and environmental measures, we should ensure that the surgical mask or tissues are available, or disposable receptacles are available at the ART centers. Also, as I was saying, ventilation should be maintained, and more than 12 air exchanges per hour should be ensured. All windows and ventilators should be open. More than 20% area should have unobstructed openings. Natural ventilation is very important, and to augment the natural ventilation, you can even plan for exhaust fans or even the table fans in the direction, so that the airflow is outside the ART facility. Also, in terms of the flow of the patient, it is very important, as we were talking, like, about the risk of cross infection, like, when the patient goes from one node to another node. So in the first diagram, you can see, like, the kind of crisscross which is happening, and there's no unilateral flow. So patient would come here from one direction, and then patient would go to some other direction, then go to another direction, and there's a lot of mixing for the patients. And what we recommend is, like, if there are patients with respiratory symptoms or cough symptomatics, they should be prioritized, and they should not be asked to stand in the queues, and they should be provided consultation and medicines at the earliest, and their unilateral flow should be maintained, so that there is no mixing of the patient. So this is one of the ART centers where, like, all these crisscross was happening, and what was just needed was just to see the patient flow, and then, like, once the entire flow was analyzed, it was realized that if you just do some minor adjustment in terms of the sitting arrangement of the healthcare staff, the flow can be maintained. And here you can see, like, there is no mixing of the patient. So once the patient comes from outside, and then he goes outside. Then, as I was saying, the triage and fast tracking of the patients who are having any respiratory symptoms should be done, and patients should be educated on cough hygiene, especially if they are having any respiratory symptoms. They should cover the mouth, and they should be provided disposable surgical mask at the ART centers. Also, the care coordinator at the ART center should facilitate that these patients are fast tracked and they are not made to stand in queue with other patients. Patients with presumptive TB should be referred for NAT testing or for appropriate investigation as early as possible. And the ART centers should have signages displaying about the airborne infection control practices at the ART centers. So I think I already discussed about the PP and also the screening of the healthcare workers. So as per the infection control practice guidelines, all the healthcare workers should be periodically screened for tuberculosis. And also HIV positive health workers should get a comprehensive package of care, which includes ART. So because especially in our ART centers, care coordinator is a positive person, and also we have outreach workers, which are most of the time positive people. So it should be ensured that they are provided ART and also the TPT. if they have not already been provided. Also, screening of for hepatitis for all healthcare providers needs to be done irrespective of the symptom. That is again part of the guidelines, and all the staff at the ART centers should be vaccinated for hepatitis B. Now coming to the last section is the post-exposure prophylaxis. So for post-exposure prophylaxis, these are the 6 steps which are recommended, and the prophylaxis should be preferably given within 72 hours of the exposure. So in terms of the steps, first is the management of the exposed site. And we will discuss about this in more details, especially for occupational exposure. Then establish eligibility for PEP. You have to examine the patient and see that the patient needs post-exposure prophylaxis. Then if the counseling of the patient for PEP, lab evaluation of the patient, then prescribing PEP and follow-up. So this is basically the management of the exposed site, and this has been dealt in most of our technical sessions. So because of the time, I'll not go in detail, but these slides would be available to you. Then coming to the eligibility of the PEP. So the eligibility is determined basically by 2 things. One is the source of the HIV status. Sorry, the source HIV status, and then the type and severity of the exposure. But in the settings where the background HIV prevalence is very high, or the status of the source is not known, in those cases, all exposures may be considered for post-exposure prophylaxis. And because you do not know the status of the source, the PEP should not be delayed for this reason. So coming to the exposure, like which exposures would warrant PEP, these are basically they are based on the type of fluid. So if the patient, if the exposure has happened to the blood or blood-stained saliva, breast milk, genital secretions, cerebrospinal fluid, amniotic fluid, or peritoneal fluid, synovial fluid. So in those cases, you would consider the exposure as exposure requiring PEP. All cases should be assessed clinically, and healthcare providers should make decision as to whether the actual exposure constitutes a significant risk or not. Then the other piece is type of exposure. So if the exposure during the exposure, if the mucous membrane has been involved, sexual exposure or splashes to the eye, nose, or oral cavity, those are considered to be of significant risk. If the exposure is of the parenteral mode, especially an accident with a high caliber needle, a deep wound, or transmission of a significant volume of blood, or an accident with a needle stick injury. So in those cases, these type of exposures are considered to be having a high risk of transmission or developing HIV. So exposures which do not require PEP are the when the exposed individual is already HIV positive, when the source is established to be HIV negative, you know for sure that the source is negative, exposure to the bodily fluid that does not pose a significant risk, like tears, blood-stained saliva, urine, or sweat, or exposure to the intact skin. Counseling for PEP. So once you have assessed that the patient is eligible for PEP and the exposure carries a significant risk for HIV, in those cases, the patient should be provided appropriate counseling, and during the counseling, their consent should also be taken. So PEP has to be given with the consent, informed consent of the patient. It is not mandatory, and patient should be counseled for safe sex practices till both baseline and the 3-month follow-up test have been found negative. And then obviously, I mean, after an exposure, the person really gets very panicky, very stressed. So psychosocial support has to be provided. Anxiety level needs to be brought down. Patient needs to be counseled and explain the benefits of PEP and also to adhere to the PEP. Lab investigations, HIV Hep B and Hep C testing of the exposed person should be done as early as possible. But the decision for testing HIV has to be done based on the informed consent of the exposed person. So you cannot like force HIV testing, obviously. A positive HIV status at baseline, I mean, if the patient is already HIV positive at the baseline, so that means this patient needs care and treatment if already not on ART, so he should be referred to ART. He does not need PEP anyways. Then prescribing PEP, as PEP has like no highest efficacy if given within 2 hours of exposure. So time should not be wasted, as in when an exposure is reported and you have ascertained the eligibility that this exposure needs PEP, PEP should be started. But even if an exposure is reported a bit late and 72 hours have lapsed, even in those cases, PEP should still be offered. It may not be that efficacious, but it would have some beneficial effect for the patient. Prophylaxis needs to be continued for 28 days. So this is very important part of the counseling, and the patient needs to be given drugs, or he needs to get the drugs for 28 days. Then the exposure needs to be reported to the appropriate authority. So in your hospital, like whatever the guidelines are, it has to be like any occupational exposure has to be reported. And you if you are having any confusion like which ART regimen to be used, or in those cases like whatever is available at the ART center or wherever you are in those settings, that the ART should be uses. In case with the exposure from a person on ART, you start with the available 3 drugs at least, and if you are in doubt, then you can seek an expert opinion or take opinion from the SASEP. In case of highly treatment experienced source, start the first dose as per guidelines, and then again like refer the case to SASEP for expert opinion. So there's a change in the PEP regimens now. So earlier efavirenz based regimen used to be like preferred regimen. Now with the availability of the DTG, TLD, tenofovir, lamivudine, and dolutegravir is the preferred regimen for all exposures in adults and adolescents more than 10 years and weighing 30 kg. And then you have alternate regimen available if the patient is having any if DTG is not available. In those cases, a PI based regimen can be used as a preferred regimen, and otherwise efavirenz based regimen can be used. For children who are more than 20 kgs and more than 6 years of age, for them zidovudine, lamivudine, and DTG 50 milligram can be used, and if these patients are anemic, then zidovudine can be replaced by abacavir. For children less than 20 kgs of weight or less than 6 years of age, for them zidovudine, lamivudine with a PI lopinavir ritonavir has to be used, and if the patient is anemic, then you can use abacavir instead of zidovudine. Coming to the follow-up, enhanced adherence counseling is very important in these patients, as we were discussing that these patients are really like very stressed out, and they're actually not patients. So exposed people are really like very stressed out. They are really panicked. So they have to be like counseled, and every time like they come for a consultation, they should be again adherence should be reiterated. Follow-up needs to be done at 7 days, 14 days, 28 days, and 12 weeks after starting PEP. And the HIV testing after the once you will do at baseline, and after that it has to be done at 4 weeks. If negative, then it has to be repeated again at 12 weeks. And then whenever the patient is coming for the follow-up visit, patient needs to be assessed and managed for any adverse effects of the drugs. And you have to monitor the acute seroconversion illness within 3 to 6 weeks after exposure. If suspected, then you refer the patient for treatment services. For the availability of the PEP drugs, so PEP drugs are really required on an urgent basis, and as we said that they should be preferably given within 2 hours once the decision is made that the PEP is required. And therefore, these drugs should be made available in the casualty, OT, labor rooms, ICU, and emergency ward in the hospitals with proper documentation. A regular check should be made for the expiry of these drugs with the replacement of short expiry drugs. So if you can bring back the short expiry drugs to the ART centers, and for these locations, you should keep long expiry drugs there. PEP drugs should be, PEP cases should be documented in accidental exposure form, including the consent form. So this form is available with the ART centers, and this should be used whenever the patient is being initiated on PEP. And a PEP register and reporting of the drug consumption should be, the record should be maintained in the PEP register also. And about the drugs, the consumption should be mentioned or indicated in the IMS or the SOCH. So with this, we come to the end of this session, and then we can open for discussion.
Thank you, ma'am. Participants can unmute their mics if they have any questions.
Hello, madam. Good afternoon.
Good afternoon.
How do you rule out the risk of transmission of HIV with respect to the window period?
You have to provide PEP.
No, we can't know who is in window period, who is not in window period. The source when tested is HIV negative.
Right.
And the guidelines, it is mentioned that if the source is negative, there's no need for PEP. But there's always a risk of window period, right?
So basically, you have to use your clinical discretion here. And as I said, especially in the areas where the prevalence of HIV is really high. Okay. So if you're getting patients from even in India, there are districts or pockets where the prevalence is very high, and there are pockets where you have very low or very minimal prevalence. So if you know to which area the patient belongs to and the prevalence is really high, then to be on safer side, it is good to give PEP.
Because at times we do get healthcare personnel who do not want to take any risk.
Right.
This window period. How much ever counseling we do, they say, but there's always a risk of window period. Please provide us, and we have provided them PEP. So I just wanted to ask.
That is fine. I think that call you can take.
Okay, thank you.
So I think the best good practice is to provide PEP. Yes, whenever you are in doubt, it's good to provide.
Whenever the person feels that he should take, it's always. And we need to give it.
And especially if you have ascertained about that type of exposure.
Yes. And how about rape cases, madam?
Rape cases are to be provided PEP.
Okay. They also have to be. We have to write it down in PEP register.
Yes.
Accidental exposure.
Yes.
Same consent form, everything.
Same consent form has to be used, and obviously the authorities or the people who are dealing with that case need to be informed.
Yes, we do get requests from casualty or PEP.
No, so as per guidelines, all rape cases are to be provided PEP.
Okay.
Adults as well as children.
Okay, thank you.
Ma'am, good afternoon. Just to, in continuation of the previous question, even if the source is negative, like if the rape accused is caught and the test has been performed and the source is negative, even then we have to provide the PEP?
Again, it would depend on the background prevalence, I would say. And if you are unsure, it is better to provide PEP.
Background and then the type of exposure.
She's talking about the rape case. So obviously, I think this exposure warrants PEP. And if you are unsure of the source status, it is fine. You provide PEP.
And what about the source? If the source is on third line ART or any such scenario, should you look into the regimen and then provide PEP?
So see, I think for now the advantage is DTG is a new drug in the program.
Yes, yes.
So I think it would be
no such
so
doubt will be there.
so it is it I think it would be effective like no, for most of the rape for most of the cases requiring PEP.
Yes.
It ideally like no, for the patients who are treatment experienced, who are on second line and third line, for these cases once you start the patients on I mean the preferred regimen is TLD, you start these patients on TLD and then you can take a advice from SASIP based on the treatment history of the patient.
Madam, another question. It's not related to the chapters discussed today. Can I ask?
Yeah, you may, but okay. I'm not sure whether I'll be able to answer.
I think you only discussed about those topics also. Recently, we had a second line ANC on second line. She was on TLAR. First line was ZLN and SLN. Okay. And baby had to be provided with dual prophylaxis. Okay.
Right.
We consulted the PCOE, Indira Gandhi, IGICH, and we were told that the baby cannot be put on lopinavir for initial 2 weeks, and only after 2 weeks it can be started on lopinavir. And we were advised to give only zidovudine and nevirapine initially. And after 2 weeks also, we were unable to get lopinavir syrup. Only pellets were available. How to handle such cases, madam?
I think under program, the syrups are being procured. So I'm not sure if somebody is there from NACO. This is more of a availability issue, what you're discussing. So maybe you can discuss with your PCOE about the availability.
Could not give us any answer because lopinavir syrup was not available anywhere. Even to procure, we requested DAPCO to procure. Even outside market also, it was not available anywhere. And finally, we had to give the baby zidovudine and nevirapine. Both were failing regimens for the mother.
Right.
So is it about the prophylaxis you are talking about, or the
prophylaxis?
So, okay, so lopinavir, ritonavir pellets are there under program, and that can be given to the baby. You know why lopinavir, ritonavir syrup is not being given? You need to understand that. You know, there was only one vendor. That was the one reason, and the second thing is for the infant, like as PCOE has rightly mentioned to you, like initial 2 weeks we may not give lopinavir, ritonavir because the liver is not mature of the infant, so they may not be like able to handle LPVR syrup.
Yes,
that's for the infants we can't give.
Yes.
So, and the second thing is the availability of the LPVR syrup, because there was only one vendor who was preparing. That's why pellets were introduced into the program.
Yes, sir.
So now for all the children, those who are eligible for LPVR, we can give pellets.
But pellets in a newborn baby, because it's not
newborn, you can't give. Newborn you can't give. So in that case, for prophylaxis, that is the ideal scenario is zidovudine is better than nevirapine. If you are like, if the mother is on second line ART, you can still give zidovudine syrup to the baby. That will work for the baby.
But zidovudine is a failing regimen for mother, right?
That's fine. That's fine. But the failing regime was entire regime, ZLN or SLN, right?
Yes.
That was the
Yes,
first
sir.
regime.
Yes, sir.
Currently, mother is on second line regime.
Yes.
Nevirapine will not be working because nevirapine may have some resistance to the NNRTI. But zidovudine will be safer to give, and that will not create that much resistance. You can give safely. Maybe for the extended period of time, may not be for 6 weeks. You can give it for the 12 weeks. And then you have to test the baby, and then if baby turned out positive, you may need to go for the ART, whatever is like.
No, we were advised to give both zidovudine and nevirapine by PCOE, and we given accordingly.
Okay.
That is.
I think we can have more offline discussion on this.
Okay, madam. Thank you.
Ma'am, can we take 2 questions?
Yes.
Yeah. One is, there was a young a student who had a sexual encounter, unprotected sex, and he wanted to have PP, but the ARDC had given him the contact number for a pharmacy, private pharmacy, and then asked him to purchase tablets of TDF, 3TC, and DTG. The question is, what could have been done better or different?
So this was a student who
Yeah.
got a accidental unprotected
right.
sex, huh? Yeah. So I think what was done was appropriate.
Okay. Second question. Many of the PHCs and CHCs request to provide 1 dose of PP. Is this dose provide from ART, or should they procure it locally?
The CHCs and the PHCs?
Yes.
So basically, initially there used to be a guideline that NHM should procure the PEP drugs for CHCs and PHCs. But I think because most of these CHCs and PHCs have the NACO ICTC and the counselor is available, it is okay to keep the post-exposure prophylaxis doses from the ART stocks.
Sorry, ma'am, just one last question. Can PP be given to non-medical professionals from the ART center? Can it be issued from the ART center to non-medicals?
Non-medical, when you're talking about occupational exposure, I mean, obviously it won't be occupational exposure, I'm assuming. So if it is a non-occupational exposure, you can do a prescription, but not provide the drugs.
Thank you, ma'am. No more questions in the chat box. Participants can write back to us if they have any questions.
Yes,
please.
Sorry to interrupt, ma'am. Actually, I got disconnected as soon as I asked the question. Hello?
Yeah.
Yes, ma'am.
Go ahead, please.
Yes, sorry, ma'am. I got disconnected as soon as I asked the question. Actually, we had a patient a month ago, where she was raped. It was a post-exposure case, and the accused was HIV negative but hepatitis B positive. So I gave her prophylaxis for that, but not the HIV. So I just wanted to be sure, even if the status is negative, we should be going for it.
So again, it would depend on your prevalence rates. So if somebody is negative, the test has been done and you know the status of the source, so the likeliness of this person to be in a window period, if you are in a setting where the HIV prevalence is very low, is very, very, very minimal. Yeah. But if you think and obviously that this person comes from a setting and he could be have some exposure to HIV and could be in a window period, it is safer to give PEP. But most in most cases, when you have in these low prevalence settings, somebody is negative, then this likeliness of this person to be in the window period would be very, very minimal.
Ma'am, him being hepatitis B positive, does it make it highly likely that he's in window period? Because
could be.
I may want to reconsider, because I did not give her, because it's a low prevalence area, I did not give her the HIV prophylaxis, but now, okay. Okay, thank you, ma'am.
Thank you, Reshu ma'am, for the informative session. Thank you, sir, for joining us and giving the opening remarks. Thank you to all the patients. Yeah, ma'am, please go ahead.
Ma'am, I want to know one question.
Yes, ma'am.
In sexual rape cases, is it necessary to diagnose the rape, confirmation of rape cases, then start PEP?
No, so I think that's what I said. If you don't know the status of the source, that does not mean that you have to delay PEP.
No, we don't know the status of the source, because this problem is coming in our ART centers. I have talked about to start PEP for sexual rape cases, but the authority are saying it will take more than 72 hours time for the confirmation of the sexual rape cases. Then what we have to do? We have to do first confirmation of the sexual rape cases and then start PEP?
No, you can start PEP and simultaneously confirmation can be done.
Okay. Thank you, ma'am.
Yeah, thank you, Reshu ma'am, for your time.
Madam, one last question.
Yes, ma'am.
Sorry. And we can, I mean, the efficacy of PEP drugs is best if given within 72 hours. But it was also mentioned that if a person comes late, it can still be given. What is this duration like? For how long can we give? Like if the person comes and asks for PEP after 10 days, can we give? What is the time limit?
So actually, I think the studies like no, they are not available on PEP, and especially with the newer regimens also, like which are like comparatively more effective. So PEP could be effective in these cases and may not be. We are not very sure about the efficacy, but I think like no, in terms of where you don't know something which is not like proven, it is better to try.
Okay. Even after 10 days, if any person...
Yeah, I won't be able to tell you like no what should be the cutoff. That would depend on your like no discretion. Like no, if you ask me like after 6 months, obviously
no, not 6 months.
So, but then like no, if you know that immediate exposure has happened, it is good to like no at least give a drug.
And also counsel them that they may not get the full efficacy.
Excuse me, madam. Can I interrupt?
Information.
Sir, I really request you. I think we'll have to end the session now. We are already 40 minutes ahead of it now.
You can post your questions, and or you can put them in the chat box, and we'll respond to them.
Right. Or you can even just reply to the email that you have received, the invite that you have received, and we'll receive your questions.
Okay. Thank you.
Yeah. Thank you so much. Thank you to all the participants for patient listening, and extremely sorry that we couldn't take additional questions now. Please post your questions as reply to the email that you have received as the NDLS invite. Thank you.
Thank you so much, everyone.